I am so excited to introduce you to our next speaker. I had a lovely conversation with him in the back. His name is Ritter, and he's the director. He directs the Memory and Cognitive Disorders Program in Hoag Hospital. And he's going to be talking to you about why changes in the cerebellum lead to cognitive and behavioral problems. So please help me in welcoming Aaron.
Gosh, I got some entry music there, huh? Well, thank you so much for having me. This is my second time at this conference. I loved my first experience in Las Vegas. It's my hometown. I'm a vegan, a lost vegan. And I was really excited to see that we're going to be at Disney, and I was hoping it was going to be in California Disney, but it was Florida Disney because I live right down the street from Disneyland in California. It took a little bit longer to get here today, but I'm happy to be here. Thank you so much for having me. So a couple disclaimers, and then a little bit about myself. I primarily see patients with Alzheimer's disease, so I do some consulting for Alzheimer's disease companies or getting some new medicines for Alzheimer's. I think this is my TMI slide. I am a cat person. That is my disclosure. Any other cat people? There's like 3 of us. Okay. I went with the dog presentation today, so we can have the cat one later. It's got bigger words and more complex, but doing the cat presentation. Anyway, and then we're going to talk a little bit about off-label prescribing, so prescriptions that we give that have not been approved by the FDA. So today's objectives, we'll talk a little bit about the unique anatomy of the cerebellum, this really unique part of the brain. We're going to kind of discuss how the anatomy of the cerebellum affects behavior. So neuropsychology is the study of how the brain affects our psychology. And then we'll talk a little bit about how that brain structure affects behaviors as well. And then we'll know some of the common non-motor symptoms in ataxia. So we tend to focus a lot on the motor symptoms. We'll talk a little bit more about the non-motor symptoms today. And I grew up with David Letterman, that's top 10 things. I remember him, and so we're going to do 10 things today to know about the neuropsychology of the cerebellum and ataxia. All right, so number 1, the cerebellum is Latin for little brain. So it's that little stuck-on part that looks a little bit smaller than the cerebrum. The cerebrum is that sort of irregularly folded part of the brain, and then the cerebellum is the sort of highly structured organ that sits below the cerebellum. It's little brain. But did you know that there's some species of animals where the cerebellum and the cerebrum are the same size? So it's kind of cool. But in humans, it's the smaller part of the brain. It's right next to the spinal cord, and we'll see how that's important as we go forward. The cerebellum has a very unique structure, and if we look at the picture there, we can see that the cerebrum's kind of irregularly shaped. It kind of has different folds and gyruses, and it looks kind of different. And what we see when we're seeing patients in my clinic, we see that the cerebrum can be very different depending on a person's past experiences. It can be different depending on a person's blood supply, and it changes as we get older. The cerebellum, on the other hand, is very highly structured. It's very it looks like an accordion folded over. And the structure of the cerebellum is different than the cerebrum because it does different things, and we'll go through that a little bit. The structure that it's most close to is a structure called the pons, which sits right above the spinal cord, and the cerebellum and the pons communicate, and they're in constant communication. So this is an important anatomy of the cerebellum, is its relationship to the pons and the spinal cord. The cerebellum has sort of a unique gray matter sort of structure, the cortex of the cerebellum. And we can see in this picture, what I think is most importantly is to see how many cells are in that layer called the granular layer. It's a layer that has a ton of different cells, and this is why the cerebellum has just as many neurons in it as the cerebrum. So even though it looks kind of different and it's a lot smaller, the number of cells packed into the cerebellum is incredible. And that Purkinje layer is an incredibly important cell layer, and that's where a lot of potential to go wrong, and so that Purkinje layer is often the one that's affected by some of our hereditary degenerative diseases. There's also these kind of really unique cells that kind of infiltrate the cerebellum called the climbing fibers, and these are these cells that kind of educate the cerebellum how to do stuff. So the structure of the cerebellum is pretty fascinating. Although I realize I'm getting kind of nerdy here, but I do think that this is a really cool slide just to see the structure of the cerebellum. And then the cerebellum, like I said before, is kind of folded over like an accordion. You can kind of see, and it gives it a lot of surface area. So the cerebellum has a lot of surface area, and when you cut it down the middle, it kind of looks like the folds of a tree. So it's kind of cool to see things in nature be recapitulated in human anatomy. I think that's fascinating to see. And then there's 4 nuclei in the middle of the cerebellum, and they're kind of like the way stations and the telephone system that kind of connects the cerebellum to the rest of the brain. And those, so those are very important, along with these 3 peduncles. Just like in Southern California, there's not enough highways to go through. The cerebellum's got 3 major highways that we kind of transfer information. So the cerebellum is kind of a unique structure, and it's completely different than the rest of the brain. And this is just kind of a cross-section of the cerebellum and all the different highways that information passes back and forth through the brain to the cerebellum. And like I said, it's like a map of Southern California. The major highways, we've got the superior, middle, and inferior peduncle, and those are the main passageways which information goes from the brain, the spinal cord, into the cerebellum. And so we see all these connections that the cerebellum has to really key parts of the brain. And we're going to see why that is in just another slide. But it's important to see that the connections that the cerebellum has to the rest of the brain are pretty incredible, especially through the thalamus, which is the kind of way station of the brain, and to other important parts of the brain. So we see that the cerebellum and the thalamus and the pons are really well connected. So I think the overall takeaway is this is a really well connected sort of part of the brain. It's a sort of a place that has a lot of different connections to the rest of the brain. And just like the cerebrum, where we have different lobes, we have 4 lobes of the cerebrum, that do slightly different things. The cerebellum has its own lobes, and in general, it kind of does some organization. So like functioning cells kind of sit together and function together. And in the cerebellum, we generally have kind of 3 different areas, and they do slightly different things. And you can kind of tease that out a little bit, particularly the floccular nodular lobe, which sits underneath, and that's very highly involved in eye movements and coordinating eye movements. And so we see this sort of unique anatomy of the cerebellum. And so I think in general, there's a lot of overlap. The brain doesn't quite function one-to-one. It kind of functions as networks of cells. But in general, we can say that the anterior part of the cerebellum kind of helps with stability, and then the sort of back part functions with motor movements, and then the floccular nodular eye movements. And we learn more, but these connections are kind of general broad-based descriptions of what the cerebellum does. And so right around kind of the time when neurology was really taking off in the 1800s, we had some really interesting anatomists that were doing some fascinating work, and these guys are operating in a sort of a environment where they didn't have TikTok and they couldn't communicate. So these guys are really Renaissance men doing a lot of different things and finding out a lot about the brain. And there was a French anatomist that found out that the cerebellum, when you had lesion pigeons' cerebellum connections, could still move their arms, but they couldn't do it in a coordinated way. So we started to realize the cerebellum was really about coordinating motor movements, and this is a fascinating work, and that sort of is the sort of way we started thinking about the cerebellum. And so that's where we first started to learn about the cerebellum itself. And so I think what it kind of turns out to be, and this is incredibly simplifying the structure of the cerebellum, but it's really kind of like a finishing school for the ideas that are generated from the cerebrum. The cerebellum kind of takes that and makes it really specific and particular. So movements and thoughts and things are generated from the cerebrum, which can do sort of unsupervised learning, and then the cerebellum kind of helps make that particular finite ability. So when in the clinic, when we're testing the function of the cerebellum, we all do this kind of funny test where we're touching the nose and back to the finger. We're testing the function of the cerebellum and its ability to be very precise in its movements. That's different. If you have a stroke in the cerebrum, patients can't even initiate movement. So I don't know if people have seen people that have had major strokes and you ask them to move, they can't move because the cerebrum is generating the movement. Whereas if you have a stroke in the cerebellum, we often see this, we can't control the finite movement. So we can see the different functions. So the cerebrum and the cerebellum kind of work in conjunction. They do kind of separate things. And I think over time, there's theories about how the brain works are very similar to how computers work. And the idea is that the cerebrum kind of teaches the cerebellum how to do certain things really well and sort of passes off that information. So a lot of the automatic things we do, like put our shoes on and kind of automatic tying our shoes and moving, are really kind of designated to the cerebellum. This is a really broad simplification of what it does, but that's kind of the function of the cerebellum and how those two organs kind of work together to produce movement and activity. But what it turns out to be is that the cerebellum has more than just motor connections. We know it's not just motor movement that the cerebellum is involved in, and as we've been able to kind of look at more closely at the anatomy, that the connections between the cerebellum and the cerebrum go more to the just motor activity areas. They're part of cognitive activities as well, and some behavioral activities as well. So, and we can kind of break them down more broadly. Again, this is more to the anatomy. We tend to think of the anterior lobule. This is a part within the cerebellum, is maybe much more for movements, and the posterior lobule much more for our thoughts and our behaviors and our emotions. So it's, again, there's this sort of organization of the brain that's fascinating and does a lot of different things. And so I think right around the late 1990s, 2000s, we had a lot of breakthroughs from an idea of what the cerebellum does cognitively from Professor Schwammen, and he sort of coined the term of the cerebellar cognitive affective syndrome. I think he's here. He's a guy that looks like Liam Neeson, but 6 inches taller and has a cooler accent, so you can see Dr. Schwammen and ask him questions about the Schwammen syndrome. But this is really the breakthrough in terms of understanding what the cerebellum does cognitively, and we see this primarily from people that have major strokes or cerebritis. I started in pediatrics, and we had a patient that went for surgery, a brain tumor, and came out of surgery with the Schwammen's syndrome, and that over time improved. But we could see some very specific symptoms that can come when you damage the cerebellum acutely. So we see things like executive functioning, the ability to plan and reason, sometimes seeing things in space. Language was affected, and then we saw some changes in a person's sort of emotions, their ability to regulate their emotions. So this is the cerebellar cognitive affective syndrome. This is a huge breakthrough in understanding how the cerebellum affects cognitive functioning. And so now we have this sort of idea of this dysmetria of thought. So we apply dysmetria to motor activity, but we're starting to think about dysmetria of thought when it comes to the cerebellum, that the cerebellum itself modulates some of those thoughts and emotions and behaviors. And so I kind of think about this universal cerebellar impairment, which we see just kind of little changes in our cognitive ability when the cerebellum is involved, and that's primarily with executive functioning. In Alzheimer's disease, we see the gray matter, the cerebrum is affected, and people can't form new memories, they lose their language abilities, they lose their sort of abstract reasoning abilities. When the cerebellum is involved, it's more of that fine-tuning of that. So when we've done testing of the cerebellum, when we do formal cognitive assessments, we see changes primarily in executive function. We call this a cognitive dysmetria. And it turns out that when it comes to the SCAs, it sort of we see an association between how much of the pathology is leaving the cerebellum to how much we may see on the cognitive tests. So there are certain SCAs that affect more broadly the brain, and including the basal ganglia, like in SCA 17, may have a little bit more different cognitive symptoms, and it may look a little bit more like Parkinson's disease than other SCAs, which may be limited to the cerebellum and may have more of this cognitive dysmetria. So as opposed to Alzheimer's disease, where we're seeing really big changes in the brain itself, we're seeing only subtle changes in the cerebellum, so we see less of the cognitive deficits on our testing. This is a test that we use in our clinic. It's a volumetric analysis, which actually can measure the brain volume itself, and I find that incredibly helpful. And it's a sort of a sign of some of the new technologies that are going to be able to help us really diagnose things a lot better. And so we often get this MRI in patients with cognitive impairment to see what the sort of impact of each of the diseases is on the brain function. So I was trained as a psychiatrist as part of my training. And so one of the things that I think is incredibly important and understudied is how do neurologic disease, how does changes in the brain affect psychiatric symptoms? And we see in certain diseases, certain neurologic diseases, certain patterns of symptoms. And that's true for diseases that affect the cerebellum. And in general, these are the kind of three most that we see, and that's depression, fatigue, and apathy. And so we're going to go through a little bit of each of those symptoms in detail. So depression is the most commonly associated neuropsychiatric symptom of an ataxia, and it's sort of around 15 to 30 to 50% of studies show that some people have depression. And so in general, this is the criteria for depression. And so I find this to be incredibly helpful to kind of run down and go over with patients to see if they may be suffering from depression. The idea that the SCA is causing the depression versus whether it's all the sort of difficulty that comes with the disease, that's a matter of debate. We're not entirely sure. It seems to be multifactorial, but depression happens commonly to human beings, and so it's good to screen for this because this is one of the things that we can really help people with. Apathy versus depression. This is a common one that I don't think even medical providers are not very well versed with understanding the difference between apathy and depression. For depression, we have the sadness, and we feel sad, we have loss of energy, poor sleep, but it's really kind of this feeling of sadness, whereas apathy is low energy. So there's a difference, and it's important to identify between the two because depression is a lot more amenable to therapy, medication therapy, whereas apathy requires sort of a behavioral plan, behavioral activation plan. So the treatments are slightly different. So if you think somebody may have depression, we would think we would want to go through these symptoms, whereas somebody has apathy, they say, I just really don't care. Like, where do you want to go to? I don't really care. I don't feel like going out. Are you sad? No, I just don't feel like doing it. So this is the most common symptom of Alzheimer's disease. A lot of Alzheimer's patients are treated for depression, which they really have apathy, and it doesn't really work. So we try to switch to more of a behavioral plan, which is getting out, being more active, doing more things, because we get these little bursts of dopamine when we're around other people. So let's talk a little bit about treatments. So we often see these symptoms. What should we do about them? I think the first thing is it's good to have an identification and awareness because we know when people have neuropsychiatric symptoms of their neurologic disease, it affects quality of life, it affects well-being, it affects a bunch of things that could be treated. So cognitive issues that may come up, I have less of a solution for those issues. We don't have great medications for cognitive issues. We'll talk about some of the behavioral lifestyle stuff that we do for patients with dementia, Alzheimer's disease, and sometimes we apply those, and I think those are helpful. And then in general, with medications we use as a medical doctor, we use a lot of medications borrowed from other conditions. So it's not a one-to-one match, but it's an argument for increased research, but also the fact that we may not have the same benefits in diseases that we have that they were initially studied for. So I think it's important to know that these are kind of the most common symptoms we may see in human beings, and they're much more common in individuals living with SCA. So the depression, irritability, fatigue. Occasionally we see some agitation, apathy, and anxiety. Less commonly, hallucinations and delusions. They have been reported in some conditions. It's important to identify these because these are also treatable, and they do are something we can have a big impact on. So for me, sort of an algorithm to approach depression is to say if it's mild, I usually use sleep as a good marker. If a person has mild depression, maybe their sleep's not affected, but once we get to moderate and severe stages of sleep, they can't sleep because they wake up at 2 or 3 in the morning wired to go, or they can't really relax, so it's that 2 or 3 a.m. wake up. That's when I start getting worried about depression and saying, biologically, something is happening in the brain that's causing it not to relax. So for me, I look for sleep, and then that's when we start using medications. Professional help is incredibly helpful. I've learned enough about the human brain to say that we have the cerebellum and then we have the subconscious, and if we get some of those thoughts out that are sitting and stewing in our subconscious, just talking about them, exposing them to the cerebellum can be helpful for depression. So everyone's had that experience. Something's really bothering them. If you talk it out, you get some feedback that can help, and we know that therapy has been proven in clinical studies to help reduce the sort of duration and severity of depression. So I think that's super important. Medications can reduce the severity. Lifestyle changes, exercise really helps depression, and that's been shown in studies. So as much as we can when we're dealing with depression to really focus on these things. If it's severe, people are starting to have suicidal thoughts or plans and things of that nature. That's a medical emergency because we can help people with those symptoms. We had a very nice presentation earlier about some of the resources. These are the resources that we use in our clinic, and they'll be at the end. But people are suffering from depression. It's worth going and visiting these websites because they do have a lot of tools that can be helpful. This is a slide that I created for myself because I think as a medical doctor, I want to know where I can be most helpful, and I think the idea of throwing pills at everybody is not a good idea, and there's certain symptoms that are much more likely to be amenable to medication therapies than there are that some just have to kind of live with. For me, I've learned that cognition, that the medications for cognition, both for Alzheimer's and for other conditions, have little benefit. So cognitive, we don't get a lot of benefit from our medications. But as we go through the sort of arrow there, we can say we can really have a big impact on a patient that's hallucinating or has depression or has insomnia. We can really help treat these things. We're less effective at treating apathy and delusions and fatigue, but I think we do a really good job of treating some of these other symptoms. This is kind of the algorithm of our clinic. We tend to use medications that are borrowed from major depressive disorders, SSRIs. They're not happy pills, so no one gets happy from them, but they're less sad pills. It's really not a very good marketing campaign, but we say when you're taking these medicines, you'll be less sad and less likely to get into that moderate to severe depression. And so we use these medications. For anxiety, we tend to use a little bit stronger medications. For agitation, we tend to use the SSRIs. If they don't work, we often go on to using antipsychotic medications that are helpful, and there's been some case reports that they've been helpful in individuals with SCA. Apathy, that does not usually respond to medications. We sometimes try stimulants, but that doesn't usually work very much. I think having a regular schedule, having OT, PT involved is important. And then for insomnia, I tend to not like to use the sleep medications, but some of the antidepressants have side effects of sleepiness, and they tend to kind of calm down the brain a little bit so we don't get that 2 or 3 o'clock in the morning wake up where we can't relax. These are all off-label. So, and then for me, seeing patients primarily with Alzheimer's disease, we focus a lot on cognition. One of the things I would say is that it's hard to sort through all the supplement data. Most of the supplement data, if you really look at the studies, show that most supplements don't actually get into the brain. I think the best study I ever saw was from USC, was about fish oil, and to get to levels for fish oil that actually get into the brain almost makes a person sick. So most of the supplements, Prevagen, all these other ones, they actually don't get into the brain, and we don't think something like Prevagen gets past the stomach. So I'm not a big supplement person. Eat a healthy diet, you get most of the stuff from these little pills that we get from a green salad. So I'm not so great on the supplements. So I think the biggest benefit you get from cognitive engagement. So there's a bunch of cognitive engagement apps out there, websites. I like Lumosity, but having a regular schedule, exercise, social engagement. And then we tend to focus on like the big four of supporting cognition. So this kind of goes for any patient that we see that has a neurologic condition, or anybody that's getting older and showing some signs of cognitive change. They tend to need help with four things. So this is where caregivers, family members can be really helpful, and that's medication management, because medications, they're crazy. It's insane. You know, the average American takes 8 pills a day, and keeping that straight, just if you could take 8 pills a day, but then you got to get it refilled, and then it runs out, and then it changes. So medication management is a huge issue. Financial assistance. So we always talk about financial assistance because we can't get that money back. There's a bunch of scammers out there. Driving is where we can do damage to other people and ourselves. And nutrition. For whatever reason, the diseases that affect the cerebrum shift our nutritional intake to being more, people crave sugar and they don't eat very much. So I see in my clinic a lot of people that are suffering or having problems because their nutrition is so difficult, it's changed so much. So for me, we kind of go through each of these medications. I think having a pill box is super important for anybody that has a cognitive issue, anybody taking more than 5 pills. There's some really great pill boxes out there. This is the Hero pill box. It's covered by some insurance plans. And you can set it, it dings, and it spits out your pills. So we try to make that easy because we know that patients with dementia, they can't take their pills. It's just too hard. It's too complicated. So we focus a lot on that. Finances, we have so many people in our clinic that have been scammed of finances. So this is a good set of advice for anybody to set things to auto pay. I do like these theft identification systems. The LifeLock is a really good one. And we kind of put spending cash on a loadable debit card. That's helpful for us. Driving, there's been a lot of work that occupational therapy can do in terms of helping assist people in assistance devices and testing of driving. But I've had folks in our clinic that have driven too long. I would say it's better to give up your driving license 10 years before, 1 day too late, because I've seen that in our practice, and that's devastating. So we spend a lot of time thinking about driving and nutrition. For whatever reason, I tend to think, and maybe this is just kind of a normal aging process, but we see this shift toward incredible sweet tooth. People just want to eat sugar all the time, and so we spend a lot of time talking about healthy proteins. And then finally, and this is my last slide, we talk about how do we keep our brain healthy, and we can learn a lot from these 9 blue zones. Apparently there's 9 blue zones in the world where people live longer, healthier, happier lives. There's one not too far from us in Loma Linda, California, but they tend to be in sort of Mediterranean areas. The number one thing on here is move, so keep your body active. That seems to be the best thing for your brain. Have a purpose, reduce stress, eat healthier. Think about beans as your main protein. That's good for me as a vegan, even though I'm a lost vegan. Protein. Limit your wine intake, or actually, alcohol intake could be helpful, but you limit it to 1 to 2 glasses. And then belong. Have a group that you're involved with, people that care about you, and have family first, and find a good social circle that lifts you up. And so I know being here at this conference is a good social circle for me. So these are just reminders about how to keep our brain healthy. And that's it for me. Those are my conclusions.